Hello, my name is Dustin Anderson, and I'm here today to do my virtual practical. I have with me my girlfriend Kelsey Shelton. She actually has a active shoulder pathology going on. I'll give you a little bit of backstory of what happened, how we evaluated it, and where we're at today with it. About 2.5 weeks ago, at the end of the day, at the end of work, I came in, and when she got home, she was like, my shoulder popped today while I was doing PRT, which is just physical readiness training. Asked her what she was doing. She said, I was just bringing my hand over my head and I felt a pop. Asked her where it hurt. She was like, it hurts right in here. She also said it hurt along the top of her back in her supraspinatus fossa. Asked her what she'd been doing the day before. She said they did a lot of push-ups, pull-ups prior to it popping this morning. So the day before it happened, she did a lot of overhead activities. No past history of shoulder injuries or anything like that, but she does have a history of martial arts background for about 7-8 years or more?
Over 10.
Over 10. And so when we first initially started the evaluation, I just wanted to see what her range of motion was. So I just had her raise her arms up, so we'll just raise her arms up right now.
Thumb up?
Yep, thumb up. All right. And it's important to note it's the right shoulder that's hurt, so let's just bring it up as high as we can. All right. So it's pretty good. Now, when it initially happened, it was, keep the other one up as high as we can. It's probably about right here.
Yeah, it was about here.
Yep. So when she got to about 9 degrees is when it really started to hurt. So go ahead and bring it back down. The next thing that I wanted her to do was just that uninjured arm. I wanted her to just bring it up into this position. All right. From what we've been learning in class, this is one way to do the apprehension test, and this is what I did. I came behind, provided a little bit of pressure, a little bit of stability right here, and just pulled the shoulder back. All right. I asked her to do it on the injured side, and I got a look. They said I can't do it. Now we've got here. I'm not going to push back, but you can sort of see from the wince on her face, she just doesn't like this. When it first happened, we just got to about right there with everything. Go ahead and relax. And she, like I said, when it happened, she said she was having the most pain right here and in the front of her shoulder. And there was an audible click every time she would move her shoulder up and down with anything. And it just happened at certain degrees. Usually when she's come here and she'd coming down, you just feel a click, and it was right here in the front of her shoulder. We did manual muscle testing, which I could feel a little bit of a contraction, especially with internal rotation. So let's go ahead and just push in. So then external rotation.
Yeah, that one still hurts.
Yeah, and it's a lot better than it was when it initially happened. I could tell that she was trying to do it, but there was just nothing there. For about 3 days, we didn't do anything because she was in quite a bit of pain, and just didn't want to aggravate the shoulder anymore. She also had more pain with her thumbs down when she was raising them up, especially in that area right here in the front of the shoulder. After the evaluation, and just a quick evaluation of the department, I figured she probably did something to her supraspinatus rotator cuff muscle, just from where the pain was on the back of her trap to where it was in the front. As we know, the supraspinatus comes through the subacromial space and attaches on the greater trochanter, and the 4 rotator cuff muscles are responsible for holding the shoulder in place while it's moving up. So the complaints of instability and the popping, especially, were indicative of that, and the pain on the outside of the shoulder was another clinical indication that it was probably a supraspinatus tear. We tried, we were doing and still doing low-level rehabilitation, just pain-free range of motion, W rows, 45-degree rows, and full can exercises with the yellow TheraBand, and clockwise and counterclockwise circles with a basketball on the wall. Not at full 90, just a little bit below. Last week, she went to the doctor and got diagnostic imaging done, and it was just ultrasound at the beginning, and found that there was a small supraspinatus tear. And the treatment now the plan now is 4 weeks of conservative treatment. If that doesn't do it, they're gonna do an MRI to see if there's any more damage to the shoulder and what's going on. So it sort of falls along the lines of what we've been learning with class as far as ultrasound and MRIs go with imaging and diagnostic uses in athletic training and sports medicine. It's not surprising that they went with the diagnostic ultrasound first because it's cheaper, it's more effective. You can actually do that in clinic, and if you don't have to spend the money to do an MRI, there's no need to. But if it doesn't get any better with treatment, there is a need to have that higher level imaging. Some things that you really want to look for, especially with a supraspinatus injury, is again, there's that pain on the outside of the shoulder, that loss of internal and external rotation. So how has this affected your activities of daily living?
I have no strength in that arm at all.
Mhm.
And I can't put my arm back, like going and grabbing my wallet,
Yep.
taking my cell phone out. It's pretty, I mean, it's getting better than when it first happened, but
Mhm.
it's still pretty painful, especially when I go back. Coming up, reaching for things, I have to just go slow. Bringing it back down is when I have to go very slow because it'll click. It just did.
Mhm.
Besides that, it's annoying. It hurts.
Yeah, and if we think about it, just from the anatomy and how the muscle's set up, like any type, I tried her to have, to do this motion where you bring your hand back. If you think about it, it's bringing that supraspinatus all the way through, it's putting it on stretch. So it's a good way to test for anything along those lines, and also maybe some biceps tendon issues. Other tests that you want to do with that one, just to rule out impingement or anything else, is yours. All right. You can just have them flip over, hold here. I'm gonna push down.
Okay.
Speeds, anything like that. You can. I'm not gonna do it on the injured side just because I know it's gonna hurt. You can also do hornblower sign or lag sign. Just contract and hold. All right. And what you're looking for is when you let go is the inability to control it coming forward, and you can do it through the different planes down here on the side as well. You can have them just put your hands right here in your stomach and just sort of push back, sort of just push into your stomach. And if they have complaints of pain or anything with that, you might want to think about subscap issues as well. All right, go ahead and relax. And some issues that I found and that I seen with just the initial evaluation at the apartment was that she has a forward, she has an anterior rotation of her shoulder, and on the injured side, she also has a winging scapula, more so than compared to the other side. And it seems like when we correct that, it makes it feel a little bit better. All right, so again, what probably would happen and cause this is just that scapular dyskinesis, that scap not moving the way it needs to, and that forward anterior rotation of the shoulder probably put her at a predisposition to have a supraspinatus injury just because of altered orthokinematics and a greater stretch on the shoulder right there. I think moving forward with rehabilitation, we're just going to progress through strength training, pain-free range of motion, and hopefully get the activities of daily living back pretty well.
Me too.